Good afternoon, everyone, and welcome to the COVID-19 Health Literacy Echo, brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. I would like to mention that we are recording this session so we can share it later. Please note that anything listed in the chat will be seen in the recording. If you prefer, you can just leave your name as it is, or you can change your only last name or only name. My name is Raquel Romero, and I hope you and your family doing well, and I'm going to be the facilitator for the session today. We have a lot of information to cover, but before we begin, I would like to ask our UT Echo IT to provide some directions for us. Click on UT.
Hello everyone, thank you for joining. Please stay muted unless you are speaking. You can use *6 on your phone if you've called in, or the microphone icon on the bottom left of your screen if you've joined on a computer. You can also communicate with the chat feature by clicking on the speech bubble icon on the navigation bar at the bottom of your window. If you're having any issues with the connection, please chat me. Thank you.
Thank you. Thank you very much, Rita, for these instructions. So additionally, please remember that if you have some issues with the connection, you can add your comments in the chat box, or you can send a private message to the UT Echo IT. Also, I would like to invite you and I encourage you to add your comments, perspectives, and questions in the chat box. We will try to address and follow up them during the session today. You can also reach out to us after this session by email. We promote interaction in our sessions, and we would like to see everyone's faces. So if you're able and you're comfortable, I invite you to join us, particularly in the discussion part of the session. And please remember that no personal health information is allowed within discussing cases and scenarios. I would like to mention this is our session number 10, and you can find recordings for all our previous sessions in our homepage. I would like to go ahead and do the introductions, and I see a large group, so we will not be able to do the introduction for all the participants. But for our attendance records, would you please add in the chat your name, title, contact information, organization, or institution that you represent. Health Confianza, it is a county-wide collaboration to improve access and the use of COVID-19 health information and service in Bejar County. I would like to say thanks to the Confianza team to provide the opportunity to engage our community members to learn together in these echo sessions. With that, and before we get started, I would like to use this space to do the introduction of our COVID-19 health nursing echo team. And I would like to start with Dr. Berger, lead specialist and moderator.
Hello, everyone. Welcome again. I'm Dr. Ruth Berggren, Professor of Medicine, Infectious Disease Specialist, and a proud member of the Health Confianza team. I'm looking forward to moderating our panel and our session today. Thank you for being here.
Thank you very much. And I would like to say hi to Dr. Barton, didactic speaker.
Hi, thank you for having me. I'm Dr. Theresa Barton. I'm pediatric infectious disease here at UT Health in San Antonio.
Thank you very much. For our panelists in this session, we have a Dr. Wu.
Hey, good afternoon. My name is Ted Wu. I'm one of the pediatric critical care doctors at UT Health San Antonio. Thanks for inviting me.
Thank you very much. And then have Dr. Pearson.
Hi, I'm Rachel Pearson. I'm a pediatric hospitalist at UT Health San Antonio, and I'm the Humanities Assistant Director at the Center for Medical Humanities and Ethics. I'm glad to be with you all today.
Thank you very much. And I would like to say thanks to our UT Echo team and also to the Health Confianza team. I would like to go ahead and have some announcements and updates for today, but I would like to start by saying thanks to each and every one of you. These sessions are possible because of you, your participation, your support, and your interest. And your feedback is very, very important for us. Please complete the pre-echo survey that you received when you register. And towards the end of the session, you're also going to receive another link for an evaluation. And for this echo series, we offer in the CME, the CNE, and Ethics Continuing Medical Education. To obtain those credits, please follow up the instructions in the chat. The code for today is 100906162. As a part of our agenda, we are going to have next didactics and long COVID syndrome in children. Following that, we have a case discussion and scenarios. I would like to mention that didactics and case discussion are important components of the ECHO model, If you have a suggestion for future topics, please reach out to us and let us know your opinion. Case-based learning is a core component of the ECHO model and offers a very distinct and unique opportunity for members to learn from others' challenges and successes. ECHO IT will share the instructions in the chat box. Finally, ECHO is all teach, all learn environment. So I invite you and I encourage you to participate in the conversation today by sharing your experience, your questions, and perspectives. With no more from my end, let's go start with our didactics. Dr. Barton, this is your space. Take it away when you are ready. Dr. Barton, you are muted.
So are you able to see my screen, or are you seeing the presenter view again?
We're currently seeing presenter view.
All right, there we go.
Yes, perfect.
All right, so thank you for inviting me to speak today. I know that we recently had a session on sort of long COVID or post-COVID syndromes in adults, and for the pediatricians among us, this has been also an emerging concern, and one that I've, of course, received many referrals for. So I have no financial conflicts of interest to disclose as far as the CME is concerned. I am going to say, however, I'm going to disclose that I'm not a PM&R specialist nor a cardiologist or a neurologist or a psychiatrist, but I do, throughout my career in HIV medicine, I am kind of by default an adolescent medicine provider, and that is largely the population who seems to be affected with post-COVID syndromes, and so hopefully that lends me a little bit of credibility or expertise in this area. So today we're going to be going through some of the immune responses to SARS-CoV-2 virus and how those might relate to complications that we see from COVID-19 illnesses. We're going to talk about what long COVID syndrome actually is and how we might define it. And then hopefully most importantly, identify some strategies to evaluate and to facilitate recovery from these illnesses. So briefly, as with many viruses, our bodies respond to SARS-CoV-2 virus in two facets. One is with antibody production, where antibody binds to the virus and prevents it from binding to its target cell, and also facilitates its clearance by the other immune cells, as well as a cellular response where you have cytotoxic T cells being directed by your helper T cells to attack and kill infected cells. And so the different types of immune responses that we see to that infection depends on how much of those two facets of our immune system are being activated. So we know that cytokine storms have been associated with severe respiratory disease, the COVID pneumonias and the respiratory failures. This is largely a part of the cellular immune response, again, that is mediated by the CD4 helper lymphocytes whose job is to coordinate what the cells of our immune system do. These CD4 cells secrete cytokines, and very importantly, they also downregulate your response. So once you're getting over your infection, your CD4 cells are supposed to tell your other cells to cool it and to stop attacking everything, so that you don't remain in an inflammatory state after having an infection. And so it's been proposed that persistent activation of this cellular response, or perhaps inappropriate cellular responses, may lead to prolonged disease. And there hasn't been a lot of evidence for persistent viral infection, although I may have a slide coming up that brings that into question. So there have been several studies looking at, what is the immunologic milieu of people who are displaying prolonged symptoms after a COVID infection. And this was a study that I thought was was good. It's not something that I think from a clinician standpoint that's that practical, but they did compare subjects who had prolonged symptoms with those who had COVID infection but who did not have prolonged symptoms. And they furthermore compared them to people who had other coronaviruses as well as people who never had COVID. And so I think it was a nicely well-controlled study, and they did find that there were certain cytokines that were statistically increased for many months following infection in the group that had prolonged COVID. And that was particularly the interferon gammas and CXCL10 and IL-8. So again, I don't know that means that much clinically for the clinician, but it's just some evidence that there may be some persistent immune activation that's involved with these prolonged symptoms. This is kind of hot off the presses. I actually added this slide last night, and this is something that hasn't been peer reviewed yet. It's one of these like pre-released prior to peer review studies, but I thought it was thought-provoking, and it's a study that's coming out of Harvard, and they had a cohort of patients who had these sort of prolonged COVID. So in here, that's the PASC, which I'll define for you in a moment. They had 63 of those, and they compared them to a cohort of patients, of subjects who had COVID-19 infection but did not have persistent symptoms. And they actually studied over time serial testing of molecular testing of various viral antigens, the S1 protein, the spike protein, and a nuclear antigen. And they actually found that 60% of the long COVID patients had persistence of the spike more than 5 months after infection, whereas none of the non-COVID patients had that. And so their hypothesis is that perhaps there is some sort of persistent reservoir of virus. But I think that this has yet to be shown in any other study, but it does, for those of us who are seeing these patients, raise questions of, should we be rethinking the role of a chronic or reactivated viral aspect. So the kind of big complications of COVID that this overreactive immune response has resulted in the acute setting, in the acute disease, are thromboembolic complications, myocarditis, and either an emergence or an unmasking of autoimmune diseases. And so these kind of three aspects have largely been responsible for a lot of the severe outcomes that we've seen, mostly in adults, but we have seen children with severe myocarditis during their infection, or with strokes during their infections, and certainly with pulmonary emboli. And so children are not spared from these complications. It's always a little bit difficult to know how frequently these happen because by the nature of the way that we look at these, we have a bias in that we study the people who are hospitalized who have severe COVID. And so, of course, the vast majority of children who develop a COVID infection had very mild disease with no sequelae. But I think that there may be, some silent sequelae that can occur. And so this is one of my favorite studies. It's not a fantastic study, but it's one of my favorite studies that demonstrates that. And this was in the early part of the pandemic, when nobody really knew what to do with this virus and whether there was any, after effects. And so athletes who were playing in Big Ten sports were being routinely screened before sporting events. And so they had about 9,000 athletes who were being serial testing for COVID. And so they knew when they became infected whether they were having symptoms or not. And so they had almost 3,000 who at some point tested positive for COVID-19. And in order to return to play, they subjected them to a battery of cardiac tests to make sure that they were appropriate to return back onto the field. And this included a very extensive cardiac evaluation with MRIs and all sorts of a battery of other functional tests. But what they found is that 2% of healthy college athletes who had COVID infection had some sign of myocarditis either during or shortly after their infection. And most of them actually either had very mild COVID infection or no COVID infection at all. And so for me as a pediatrician, this is one of the studies that kind of lets me know that, this disease is not, it may look like a mild disease in children, but there may be a significant proportion. I mean, 2% is a small percent, but, overall, given the numbers, that's a pretty prevalent or a pretty severe amount of kids to have cardiac dysfunction following a COVID infection. These are healthy people, right? Because we often hear, it's just the sick people who get complications, and that's not the case. So likewise, we also have this is sort of a neuropathic virus, and we see lots of neurologic complications, and that may be related, that's been proposed as a potential reason that people might have brain fog or these prolonged symptoms. We know that classically, especially with the original virus, that loss of taste and loss of smell were prominent symptoms, and that may be related to direct viral infection of the olfactory bulb. And we've seen, of course, strokes related to thromboembolism. We've seen encephalitis, encephalopathy. Some of that is, can be sometimes blamed on PICU stays or other medications, or again, thromboembolism. We see peripheral neuropathy, things like Guillain-Barré that may be related to molecular mimicry. And also myositis, so muscle abnormalities, again, related to cytokine storm or emergence of autoantibodies against your muscles, resulting in inflammation of those muscles. So there are a few ways that this overreactive immune response can impact the heart and the brain, and these are the systems that we're frequently seeing when we're seeing people who have these prolonged COVID syndromes. So what is, quote, long COVID? And there's a lot of terms that people use. So long COVID is sort of a generic term that really refers to a variety of different symptoms and health effects that can occur following a COVID infection. And that can be weeks or months, but not a defined time period. In the lay language, you'll hear people call themselves long haulers, or you'll see that in media. And that really means somebody who had COVID who has some kind of lingering effects, but doesn't really have a formal definition. There's been an attempt to create a more formalized definition. And so there's this entity that's being called Post-Acute Sequelae of SARS-CoV-2 infection, or PASC or PASC, depending on how many syllables you want to use in your day. And that's sort of a new syndrome that's being defined, and I have a definition coming up for that. There's also post-COVID condition, which is a little bit more vague, but that can be something new, something that is ongoing, something that emerges after resolution of the disease, occurring more than 4 weeks after the disease. And I'll just say that although these are new terms, the concept of feeling really crummy after a viral illness is not a new one. And for a long time, we've had post-viral fatigue syndrome, chronic fatigue syndrome, or myalgic encephalitis. And as the infectious disease doctor, for me, those things are kind of all the same, although I think that there are nuances. I'm sure that the PM&R people are turning over that I'm saying that. But, having seen many teenagers who had mononucleosis and have months and months and months of fatigue, that's, we see this. And so there's a lot of overlap of these various syndromes. So for, research purposes and for trying to put a definition on something, at the moment, rising to the top of that is the post-acute sequelae of SARS-CoV-2 infection, or PASC, and that is defined as symptoms that have their onset or that persist for more than 4 weeks or longer after a COVID-19 infection, that they include fatigue and a whole variety of other symptoms that I have in an upcoming slide. But this post-exertional fatigue is a dominant feature. And what that means is that somebody is feeling okay, maybe they're tired, but you're kind of going on about their business, and then they go to school or work, or Boy Scouts or whatever it is that they do, and then for the next day or so they feel absolutely wiped out. So it doesn't have to be extreme fatigue. They don't have to go to the gym for an hour, but it just means like when you're doing stuff that you kind of use up your well of energy, and then you have to spend the next day or days recuperating before you can get back up to some semblance of your baseline. It should be intrusive into their daily functioning and not explained by other conditions. So the kind of want to talk a little bit about that, because they're largely kind of neurologic symptoms that we see, and they can range from exercise intolerance, which could be dyspnea with exertion, or fatigue, or the sensation of muscle weakness. They can be pain syndromes, muscle pain, or neuropathic pain, or frequent headaches. They can have changes in cognition. This is like the brain fog that people describe, as well as enhanced anxiety or depression, and also dysautonomia. So perhaps orthostatic hypotension, thermal dysregulation, cold intolerance, heat intolerance, palpitations. And so a person who has this long COVID or PASC, they can have any number of these things. There's not just one, and it may have some, but not others, or different degrees of them. And so the way that these present kind of looks a little bit different for each patient, and that will then, I think, speak to how do you evaluate them, and how do you potentially try to get them over it. A question that I had is, well, is there anything that can predict this? And so I'll just say maybe. So certainly in the adult literature, people who have more severe disease, who are in the ICU, who have pulmonary emboli or myocardial involvement during their acute infection, have a higher risk of developing prolonged symptoms after their acute infection. But this is not universal, and we definitely see people who had a very mild infection who have ongoing symptoms. And I would say actually for children that's almost the rule, that most of them have a not particularly exciting acute infection and then go on to develop some sort of prolonged symptomatology. So is there literature about these prolonged COVID symptoms in children? So there are actually several studies, so I've just listed them here. So I think you guys will be have access to the slides, and I have a bibliography at the end as well. So there are several reports. Most of them are uncontrolled case series. And they're very widely variable in what they report. So the reports on average report about anywhere between an 8 to a 58% risk of developing prolonged symptoms following a COVID infection in children. But again, with these uncontrolled studies, that can overestimate that because they're not accounting for other illnesses or, psychological stress related to the pandemic, or other things that are going on in children's lives. And of course, they also have a bias of who's presenting themselves that is then getting captured in these series. There are some controlled cohort studies that do show that children who have COVID have a higher risk of having some sort of prolonged illness compared to children who don't have COVID. But there's really wide variability, with a 4 to 5% risk of prolonged COVID or prolonged symptoms following COVID, up to 60%. So again, there's a lot of variability, and it's a little bit difficult to know, what is the true incidence of this in children following a COVID infection. I think, to me, one of the better studies that addresses this issue is actually a study out of Denmark, because they have a nationalized healthcare system with where everybody is linked into the same electronic medical record with an ID number, and that's connected with their national lab database, so they're able to know who tested positive. And so this was a pretty interesting study that they began with 78,000 children in their registry and sent them out a questionnaire about prolonged symptoms. And they ended up with about 15,000 who had tested positive for COVID and compared them to 15,000 children who never had COVID. And so they had this sort of long COVID cohort and then the not COVID cohort. And what they found was about a quarter of the COVID cohort reported ongoing symptoms for more than 4 weeks after their infection. But interestingly, 22, almost 23% of the children in the control group who didn't have COVID reported ongoing symptoms for more than 4 weeks. So again, kind of speaking to that, other things that make children feel bad, including stress. Now, it was statistically significant because they had such a large cohort, but you can see that if you say, a quarter of kids are going to develop long COVID, that's probably overstating that, and you're probably more in the single-digit percents. Interestingly, they found of the ones who did have long COVID that 7% of them were completely asymptomatic during their acute COVID infection. Now, the incidence of this actually varied by age, and so adolescents actually had a much higher rate of prolonged symptoms, so that 25% was kind of all comers, but you can see, so this graph, the red bars are the ones who had prolonged COVID symptoms, and the blue bars are ones who did not, who were COVID infected. And so you can see that in the younger children who are here on this part of the graph, they don't have, it's not super common. They were having 10-15%, but the teenagers is when you get up into the, about half of them. And so, so this is really, and that fits with my own clinical experience, that mostly I see teenagers who are coming in, or preteens coming in with this. So when I see them, given that we know that COVID can cause cardiac complications, neurologic complications, and thromboembolic complications, for me, the important things are, I want to be sure that I don't think that this person had myocarditis and the subsequent cardiomyopathy, that I want to, examine them very carefully and get a good neurosymptom survey to rule out whether they're having perhaps a thromboembolic complication, thinking about autoimmune diseases, and thinking about things that mimic prolonged fatigue, such as hypothyroidism or depression, or Cushing syndrome or other things like that, as well as doing a mental health assessment, because this is, by its definition, a very intrusive illness. There are some recent guidelines that were published. Now, these are for adults, but they're quite applicable to children in the PM&R journal. And it's kind of a consensus guidance on how to approach patients who are presenting with prolonged fatigue and these prolonged symptoms with their COVID. And so the benchmarks of this guidance are to set achievable goals for your patients. So, they shouldn't, to be realistic. They shouldn't be expected that they're going to be running back out on the football field in a week when they feel, tired for 4 weeks. That it may take time, and to give them small steps to achieve as they recover, so that they, rather than being sort of bogged down with sort of the overwhelming, unhappiness of feeling bad, that they are achieving small steps forward so that they can look back and then say, oh yes, well, I'm better now than I was 3 weeks ago. Now I can, make it to half day of school every day instead of coming home and missing 3 days of school. Focusing on specific symptoms, so ameliorating headaches and dysautonomia and orthostatic symptoms, things like that. And then overall, just improving their physical, mental, and social well-being. Helping them to understand that this is common, that this is normal, and that they can recover, and giving them sort of goals to achieve and support. One of the major pieces of this I have found in my own practice with sort of the other viruses and chronic fatigue types of syndromes, or post-viral fatigues, is really the importance of sleep. And so teenagers in particular have the worst sleep hygiene ever, because they, they're very busy. They're much more busy than we are as adults, because they have to get up in the morning, to go to school. And then they go to school, and then they go to their after school activities, their sports or their clubs or their ROTC or whatever it is that they're doing. And then they have to come home and do homework. And then they're expected to do some family time and actually interact with other human beings. And then, of course, they want to do all the things they actually want to do, which is getting on TikTok and talking with their friends and playing video games. And so they're up until, it's pretty normal for a teenager to want to stay up until midnight. And so then they're going to bed at midnight after being on their devices, and then they're getting up at 6:30 in the morning, to get ready to go to school, and they're simply not getting enough sleep. And even for somebody who's feeling perfectly well and not having a physiologic reason for this, they can end up with a pretty significant sleep deficit. And so restoring like proper sleep-wake cycles is extremely important in addressing any kind of chronic fatiguing syndrome. And as I mentioned earlier, kind of developing coping. So the psychological support, these kids have gone usually from being somebody who's totally feeling fine, robust, doing all their stuff, to someone who feels bad all the time, and that's very, very stressful for them, and they feel very abnormal. And so rather than kind of blaming their issue on depression and saying, well, you need to go see the psychiatrist, you need to get your depression addressed, and that's going to make you feel better. It's really, I find that like, no, I need, you should go see the therapist or the psychiatrist, because I know you don't feel well, and that's really hard to cope with. And they can help you to deal with some coping skills so that when it feels overwhelming, when you feel really sad, that you can learn how to harness those feelings and address them in a way that doesn't drag you farther down. And of course, physical therapy for those who are having physical weakness or exercise intolerance, things to help to build them up. And physical therapists are great at helping them to set sort of small, achievable goals along the way. So when do they get better? Like, how long is all of this going to take? So in the adult world, so this compare cohort, it can take a long time. So in the adult world, they have about 20% of people feeling better at a year. So this is not a quick recovery. In this Danish cohort, the kids got better a little bit faster. So about up to about 75% of them were better within 5 months of that onset of that illness. Again, it kind of varied by age, where the younger ones got better more quickly, and the older ones were the ones who persisted in having lingering symptoms. And about 20% of them still had symptoms a year out. And so I think that, again, when you're setting realistic expectations for your patients, it's helpful to let them know that, yes, we expect you to recover, right? You're not going to be permanently living like this. At least we hope they're not permanently living like this. But we don't expect you to be permanently living like this, but it is going to take time, and to not expect to be back on, the basketball court in a couple of weeks. And so with that, I'd like to conclude. These are the references that I used throughout the talk. I know that's a lot of words on the slide, and so I think that you're going to have access to the slides. But as far as looking at, what is the current research that's available for children, I think these are helpful studies to look at. And so with that, I'd like to conclude and to take any questions. And I'm going to end my slideshow.
Thank you so much, Dr. Barton, for that outstanding review of a complex subject that's still evolving. I find it striking that one of the earlier studies you showed, I think it was the Danish study, showed that although more than a quarter of kids that they studied had long COVID, almost a quarter, or maybe it was 25% of kids that didn't have COVID were also experiencing these symptoms. And I've seen this in another study that I reviewed recently in clinical infectious diseases for a US cohort, where it was concluded that the symptoms of the pandemic are a thing, and that are affecting our children. And so even kids who don't have COVID are experiencing prolonged, undesirable symptoms just because of what the disruption in our society and the learning of the kids. Did you want to comment?
I mean, I think absolutely. So, this, the pandemic has really unmasked or exacerbated underlying, anxiety disorders and other, mental health issues. And so people who really didn't even recognize themselves as being particularly anxious or having problems have really faced some significant coping problems. And maybe that sometimes displays in some people as anger and, frustration and resentment at the virus and at the authorities, who make rules about the virus. And for some people that, manifest as, I'm going to hide myself in my house and never come out again for the, until the virus goes away. I think for kids, kids frequently somaticize stress. So we see very commonly kids who have, abdominal pain. And they come in with persistent abdominal pain. And one of the things when you have a kid with, persistent abdominal pain is asking about stressors in the home, things going on in your life, because many times kids don't know how to express their feelings or, other than having tantrums and things like that. And so sometimes they'll express them as headaches or tummy aches or things like that. And so, I think that kids who are having ongoing stuff, because they're living in a stressful time. And I thought that study was nicely, enumerated that for us.
So thank you for that. We're going to pause everybody for just a moment. I would ask you to please write your questions in the chat. I see one person with their hand up, and if you would be so kind as to actually put your question in print form in the chat, that would really help us. The pause that we're taking now is a bit of an interruption, but it's a necessary one. This is our 10th and final for this iteration of the ECHO series session, and we're going to run it again. And we're going to take a pause, a summer break for the month of July, but we're going to start back up again with this COVID-19 health literacy ECHO series for people who take care of patients. And we would like to ask you, our audience, about your preferred day and time. So because of that, we're going to just ask you to participate in a live poll. May I ask Cato, please, to tee up the live poll? So the first question here is, which day of the week works best for you? And please pick your single best day. And then which time of the day works best for you? Is it 7 to 8 o'clock in the morning? And we're referring to Central Standard Time here in San Antonio. Is it 8 to 9 o'clock in the morning, or is it 12 to 1? And we do recognize that people have various work schedules, and we're just trying to identify something that would be optimal for most of the people in the group. We recognize that if you've already attended a lot of these sessions, you may not be attending the next go round, but we'd still appreciate your feedback. So thank you so much. And Cato, I'll be looking to you for a cue as to whether we have enough answers to look at something, or are we going to display the response? Dr. Romero? Aha, well, it looks like 60% are saying Friday and noon hours. So it looks like the date and time that we're currently doing works pretty well. Thank you so much for that pause. I appreciate your patience with us. In addition to that kind of feedback, we of course want your feedback about our content, and there is a post session survey that will come to you regarding which you need to fill out to get your continuing education credit. But in addition to that, we have a survey that was designed by our partners at UTSA to get your specific feedback about whether this has helped you in your taking care of patients and in your communication skills and your health literacy as you care for people that have COVID or post-COVID or are trying to prevent COVID. All right, now we're going to turn into a couple of other questions. I have a question actually for Dr. Ted Wu, who has kindly joined us as a panelist, and he is a pediatric intensive care doctor. Dr. Wu, are there some critical consequences of long COVID in pediatric patients that you've taken care of?
Hey, that was a great review from Dr. Barton, and it just kind of reminded me a lot of the cases that occurred, as we were dealing with the pandemic. The ones that were really serious. I live in a different type of world, where we see the extremes of long COVID. And the ones that really come to mind are any of the thromboembolic events and the myocarditis. Those are they present. The myocarditis presents in a kind of a heart failure kind of fashion, where the patient slowly develops shortness of breath and slowly has hypoxia. And it just takes either an ER physician or a general pediatrician to do an X-ray, and they're like, "Oh my goodness, you have fulminant pulmonary edema and a very large heart on that screening X-ray," and that kind of sets forth, the workup in the hospital and kind of looking at their heart function, and kind of through that history taking, we kind of find out, oh wow, that you had COVID or your family had COVID, sometime in the months past. And then the same thing at thromboembolic events. We've seen children with usually teenagers who were healthy. They're athletes in some cases that were exposed to COVID or had COVID, and they developed something like a pulmonary embolism, so, and they result in getting treated. But, it was very scary for the family and for us. We that's something that's very rare in pediatrics, is to see pulmonary embolism. Usually we see that more in the congenital kind of patients, or patients who had some kind of congenital heart disease, is where we kind of really see that or worry about that. So we really don't really see that in healthy children. So that's my world that we saw during the pandemic.
Dr. Wu, I'm having trouble. I'm puzzled about, are these phenomena part of acute COVID as well? And so are we actually seeing people getting critically ill when they're in this sort of post-COVID phase?
Yeah, that's a great question. We've seen a mixture of both, at least these severe cases. Some of them are within that 4 weeks of COVID exposure or infection, but some were not. Some were kind of farther out, and they had recovered from their symptoms, or some didn't even have symptoms. And then they would present months down the road. So.
Thank you. I want to toss a question to Dr. Rachel Pearson, and we are going to get to a case in a little bit. I promise you that. We do have one. Dr. Pearson, you are a pediatric hospitalist, and you counsel all kinds of families when they come into the hospital and when they're leaving the hospital. And kids that are affected by long COVID can have complex and enduring symptoms. And how do you help families navigate uncertainty with respect to diagnosis and treatment, since there's so much overlap between long COVID and other things that could be going on in a child's life?
Thank you so much for that question, Dr. Berggren. So frequently my role as a hospitalist is when a kid is in that diagnostic period before the team has arrived at a diagnosis of long COVID. So I'll see a kid, for example, who's sent in from the neurology clinic because they're having, presyncopal episodes, or having some peripheral neuropathies that are unexplained. So a kid who needs some head imaging and some lab workup to look for other common causes of these symptoms. And a lot of times these are families who have been going through this for a while. Their kid started feeling strange, started having experiences they couldn't explain, went to their primary care, waited to see a specialist, and then ultimately are referred to the hospital. And so they've been dealing with it already for a long time by the time I care for them. And one conversation I always try to have at the outset of these symptoms or of these encounters is an explicit conversation about uncertainty. So that means I say something like, we're going to do these studies to make sure that if there's anything that we need to treat right now, or anything that's an emergency, that we find it and treat it, and we keep your kids safe. And I know, because in general, families they're hoping for us, after they've been through so much, they're hoping for us to find a biomarker of their kid's disease. So they're hoping, in a way, for us to find a difference in their brain imaging. They're hoping, in a way, for us to find in blood tests something that says, okay, this is it. But frequently, as Dr. Barton noted, the biomarkers of long COVID are not really biomarkers we use in clinical practice. They're just relevant to research. So often I know that my diagnostic workup is going to be normal. And so I say at the beginning of caring for these kids, often we don't find anything abnormal in the brain imaging, right? And in a way, I'm hoping for that, right? Because if we don't find anything abnormal, then I'll know that I don't need to do anything urgent to keep your kids safe. It's important to help families understand that even though initial studies may be normal, that their symptoms that their kid is experiencing are real. And I reassure them that even if we don't find a specific cause at this time, we're going to keep working to treat those symptoms. And it's important, for you as a parent and for me as a physician, to acknowledge that your kid's experience of their body is real. They're the only one who can know and communicate what they're experiencing in their body. And having those conversations from the beginning is really helpful for building trust. But one other thing I would say is that these can be frustrating encounters for physicians, because we too, or for anyone caring for kids, because we too want to find the answer. And so we have to make sure that when we feel frustrated about not finding a specific answer, when we feel like we might be moving towards that diagnosis of exclusion of long COVID, that we don't turn our own frustration into disbelief of the patient and family.
Thank you so much. You just beautifully illustrated and reviewed for us at least 4 of the 6 core communication skills that we keep emphasizing throughout our health literacy series. I heard you setting a tone of unconditional regard and respect for the patient who's suffering, as well as their family, as they grapple with uncertainty, and maybe kids are feeling like people think they're faking it and just don't want to go to school, right? So setting a respectful tone, using plain language, explaining things in terms that both the kid and the parents can understand, active listening, so you're eliciting more information as you listen, and then acknowledging the other person's perspective. Beautifully summarized for us. We really appreciate that. I'm going to ask Cato kindly bring up the case for us today. And I'm going to go ahead and present this case. I will acknowledge that the reason that we have the privilege of reviewing this case together is thanks in no small measure to Dr. Mandy Spatek and Dr. Cynthia Lopez, who made this information available to me. And I extracted it from a chart, so please forgive me if I haven't gotten everything quite perfect. This is a case of a 17-year-old male, so we're talking an adolescent, who presents to the clinic with both of his parents for sports clearance. He has dyspnea with exercise, and this is in the context of a kid who's had ongoing issues with both asthma and allergies. But in spite of having lived with his asthma in the past, he feels that he's tiring now much more quickly than his friends. And his parents say that he, quote, started sports too soon after COVID last year, unquote. However, there has been no syncope or pre-syncope during or after exercise since a single pre-syncopal episode that happened while he was playing basketball very soon after he had COVID. He has no chest pain with exercise. I'm going to read this to you because I think the physician did a beautiful job of the review of symptoms, and we can learn about what review of symptoms we want to be doing when we're seeing a potential pediatric long COVID. So stay with me. I'm going to read you this whole nice review of symptoms that we have, as well as some family history. The child has had no chest pain with exercise, no racing heart or skipped beats. There's been no family history of sudden death or anybody dying of a heart attack before age 50. There's no family history of hypertrophic cardiomyopathy or long QT syndrome or Marfan's or arrhythmia. All this she documented in her HPI. There's been no severe viral infection in the last month. There's been no history of seizures either before or after COVID. The young man has no severe or unusual headaches, no numbness or tingling of the toes. He is not missing any of his paired organs. He has had no history of heat illness in the past, has no fractures, has had no weight issues, and no rashes. The relevant past medical history is that he had gotten diagnosed with COVID-19 in February, a year earlier, a little more than a year earlier. And at that time, it was diagnosed because there was regular testing going on at his school. So he showed up for school and he had fever, fatigue, and a productive cough, was diagnosed with COVID, sent home. That lasted 6 days. And he right away resumed vigorous sports. He was experiencing some chest pain when he exercised at that time. And it would be 5 out of 10 substernal chest pain lasting about 5 minutes and then resolving. And he actually had a scary presyncopal episode while playing basketball. And this prompted a workup at that time, and he saw several specialists. He was complaining of exertional shortness of breath, and this responded nicely to a prescription for Symbicort. So these are the other things that I'm not going to reiterate stuff that I've already said, but I will mention that this was a vaccinated individual. At that point, there had not been boosting. And the only medications are Symbicort, mometasone, and albuterol. This is a high school student, and the main positives, again, at this time, fatigue, dyspnea on exertion, and poor exercise tolerance, and pertinent negatives are chest pain, palpitations, and syncope. So the family is very involved. Both of the parents came to the pediatrician and were very concerned about whether it's safe for this child to, or this young man, to go back to his sports. This is a pretty health literate family. So they're not disadvantaged particularly in that regard, but they are grappling with what families deal with. Also in the chart review that I did, I noted that he had an EKG that when he first presented that showed some non-specific ST wave changes. And he had a cardiac echo that showed slightly decreased ejection fraction. And that was with the first presentation, not now, but previously. And his ejection fraction was about 50%. And that's pretty much where we are with this case right now. This is so the pediatrician is evaluating this young man something like a year later, who has had this presentation and got a workup, but is not getting any specific therapy. And he's functional. He goes to school and he wants to play in sports, but he's not quite where he used to be athletically. So also when I did the chart review, I noticed that one specialist pointed out that there was an expert recommendation somewhere in the literature that for mild to moderate COVID-19, non-hospitalized patients should have a 14-day rest period after the resolution of their symptoms, followed by gradual introduction of an exercise load. So I'd like to ask Dr. Barton to comment on that, since you've done extensive review and are gathering quite a bit of experience. Is this a thing that you get COVID, you get well, you should not run right back out to the basketball court the next day?
So I wouldn't it be great if anytime we got sick, we're like, no, I need 14 days to recuperate before I get back to my big full activity. Actually haven't seen that being a consistently recommended strategy. So I'm not familiar with that. And I think that, it would depend individually actually on the patient as to, what kinds of symptoms they were having, but no. So I actually I'm not aware of evidence that actually that if you wait 14 days versus not waiting 14 days, that you have fewer sequelae down the road. Honestly, unless you're just waiting to see, are you going to have any residual effects during that time that might be a warning sign that something else was going on, right? So that if you were having shortness of breath, making sure that goes away before you're resuming your other activities.
Dr. Pearson, as a pediatrician who counsels a lot of people as they're leaving the hospital, and as a human being who has a whole lot of common sense, what would you advise somebody who'd had let's say a moderate case of COVID, who's now going back to their regular life? What recommendations would you make? What should parents watch for? What should people do?
Yeah. So kids who were hospitalized with their acute COVID infection, so kids who had acute respiratory failure or other complications of the infection, actually often do recommend that they wait until cleared by a cardiologist to return to full sports. However, in general, we see a lot of kids, or we did when we were doing routine COVID testing on admission to the hospital, we saw a lot of kids who were admitted to the hospital for something else and then were found to be COVID positive incidentally. For those patients, I've recommended the typical thing that I say to all parents, which is, follow your kid's lead. And if you know them so well, if they're not well enough to participate in school or in daycare or, in their regular sports activities, then don't have them participate yet. I also, with older kids, I talk to them a lot about communicating about what they're feeling in their bodies. So finding their trusted adult and telling their trusted adult, what they're feeling in their body, because there's no other way for us to know what we need to do to keep them safe. And I'm not able to see the chat, but it looks like Dr. Wu and Dr. Manlike have shared some key info.
Yes, there's some really good information in the chat that I want to bring out. Dr. Wu, if you're able to unmute, do you want to read us this quote in the chat that you just put in, or add something? I'll pause for just a second, see if you can unmute.
I don't know, but non-pediatrician, this is in 2020, the AAP did have that recommendation, but maybe one of your experts would know whether that remains the AAP's recommendation.
Dr. Ted Wu, do you want to comment?
I don't think it has changed. I don't know if there's a revision on this. I kind of remember hearing about this as well. And our cardiologists have also recommended some follow-up, for the patients that have definitely MIS-C, and then some follow-up outpatient as well.
So it sounds like this is it's an area that's still evolving. We all need to continue to watch our guidelines from our professional associations and to interpret them with a good, healthy dose of common sense and good medicine. So I really appreciate that. Dr. Mandlik has mentioned that at one point the AAP was recommending an EKG for clearance to return to sports after symptomatic COVID infection. Certainly we saw the one kid who had a pre-syncopal episode, had a few nonspecific STT wave changes. Okay, my chat is jumping around. Are there other issues related to this case, Dr. Barton, that you want to bring out for us?
I think, with this case, clearly it does raise a concern that during the acute COVID infection that he may have had some cardiac involvement with the, kind of immediate, like right when he was immediately returning at the tail end of that infection with chest pain and, intolerance and the pre-syncopal episode. And so I know that it sounds like he had a little bit of a cardiac workup during that time. And so that was not terribly abnormal or severe, but certainly not normal. Right. And so, if this patient had been referred to me, if I was seeing this patient after the fact and they were continuing to have this exercise intolerance with that history, the first thing on my radar would be like, let's make sure that your heart came back to normal after your acute infection, because it sounds like it might have been involved in the early part of your infection. And so, your careful cardiac exam, repeating your EKG to see if there's any changes there, and given the kind of extent of his initial thing, probably a referral to a cardiologist, because as I said in the beginning, I'm not a cardiologist, and I know that one of the questions was a cardiac MRI of use, and I don't feel like I'm qualified to say, yeah, he needs a cardiac MRI. I will say that in that Big 10 study, that many of the changes that they found were only seen on cardiac MRI, and not on their other battery of tests like stress tests and things like that. So there may be a role for that, but I think that that's something that if you're going down the road of thinking of a cardiac MRI, probably the cardiologist needs to be involved with that.
Right, that could get to be a pretty big, expensive proposition if all of the people with COVID are getting cardiac MRIs after they get well. Well, this is clearly an evolving area. There's a robust amount of interest in our community locally, and we need to give you some resources. And I would ask that one of my support team, whether it's Shreya Prasanna, Mia Vento, could you kindly put in the chat for us? Maybe Kato has it. We have the phone number and the website of the post-COVID care clinic at University Health System, which unfortunately at this time is not taking children as patients in post-COVID care. There is a group in the Austin area with Ascension Medical, where there is a focus on pediatric long COVID, and there's a wonderful nurse practitioner there, Nicole Higginbotham, whom I've had the opportunity to meet electronically and by phone. She has offered her email address to this group and is happy to hear from you if you would like to discuss some cases of pediatric long COVID, and she can provide some advice based on what they're seeing there in Austin. So that's, and here in San Antonio, Dr. Theresa Barton is also seeing a number of these patients. Dr. Barton, would you like to mention who you're seeing and who you'd like to have referred to you?
Sure. So I'm seeing patients in my infectious disease, my weekly infectious disease clinic at University Hospital, and so I'm happy to see. I see patients up to age 24, so I'm happy to see anybody that I guess the pediatrician is feeling like, maybe this shouldn't be going on, maybe they need a further evaluation. I kind of feel as the infectious disease doctor, since this classically hasn't been a prolonged infection per se, and really more of a post-infectious, immunologic phenomenon, that often my role is to sort of determine, do they need cardiology or brain imaging or further autoimmune testing or things like that. And I'm happy to facilitate that further testing.
All right. Thank you, Dr. Barton. I want to note that Dr. Mandy Spatek has placed another resource in the chat for us with a link to some guidelines about returning to sports from the American Academy of Pediatrics. And so I draw your attention to that. We are now at time. It's 1:02. I want to thank everybody again for their participation. Please watch for the surveys. We'll be so grateful to you if you would fill them out so we can improve. And we hope to see many of you again as we start up again after a brief summer break sometime in the month of August. Watch for our emails. Thank you. Dr. Romero, back to you.
Thank you very much, Dr. Berger, and thank you for our panelists and the presentation for today. Thank you all for being part of this learning community. This was an excellent discussion, and it was a message also in the chat about the CME, the CNE, and ethics continuing medical education. There are 2 steps to follow. This information is in the chat box, and the activity code for today is 100900162. Please complete the post-session survey, the feedback, and it's going to be open for 1 week. And as a quick reminder, please keep looking for our communication for emails, and this is in regards to our coming sessions for COVID-19 Health Literacy Echo for providers, but also launching for series, especially inviting the community health workers. We're looking forward to see you there. In the meantime, we wish you a wonderful summer. Until then, please take care, and you have a wonderful rest of the day. Thank you very much.